Welcome to Faculty Voices. Today we're going to be talking with Thomas Bossert. He's a senior lecturer emeritus in the Department of Global Health and Population of the Harvard T.H. Chan School of Public Health. Until 2022, he was the director of the International Health Systems Program, HSP, that sponsored many research projects and executive training courses. He's been very involved in the David Rockefeller Center for Latin American Studies, Dr. Class as we call ourselves, through the program he conducts in Chile. Welcome to Faculty Voices, Tom.
Thank you. It's a pleasure to be here.
Tom, you're the first person I'm ever interviewing on Faculty Voices who I actually met before I came to Harvard.
Yes.
And I knew you not as Thomas Bossert or Tom Bossert. I met you as Tio Tom.
Yes, that's true.
Can you recount a little bit about how we met each other?
Yes, I think I can. I mean, we met each other through a mutual friend who was, at the time that I met her, working in Nicaragua, and she had adopted a Nicaraguan baby. And I would visit and I would play with this baby. And so she came to call me Tio Tom or Uncle Tom, right? Which has other implications. And since you were a good friend of her mother's, I think that's how we crossed paths. You were able to connect me with that name.
Exactly. But I also connected you very deeply with Nicaragua, and I thought of you as a Latin Americanist.
Yes.
Can you talk about that period?
Yes. But maybe I should back up a little because I had a long history of becoming a Latin Americanist before I went to Central America at all. And it might be useful to talk a little bit about that because it was part of why people become interested in a certain region of the world. And I grew up in Westchester County, just north of New York City, in a little town called Pleasantville. I had not seen poverty of the kind of poverty that you can see all over Latin America. But in high school, my family went to Mexico on a program called the Experiment in International Living. And that program exposed me to real poverty in Mexico. And this was at a critical point in my life when, I was trying to decide where I wanted to go to college, where what my kind of career would be. And I remember after that trip talking to my mother and telling her that I wanted to do something to help poor people around the world, and especially to learn more about Latin America and Mexico in order to do that, right? To build my career that way. You have to remember, this is in the context of John Kennedy telling us to do something for other people, right? I've just finished reading Drew Faust's memoir, former president of Harvard. She and I graduated the same year, 1968. And she graduated from Bryn Mawr and I graduated from Princeton. And her memoir tells us a lot of the history. She's a good historian. She weaves history through her own life. And her life was quite different than mine, but the history was pretty much the same. We lived through the civil rights movement, the anti-war movement, the rise of feminism, and all of that seen from different kinds of perspectives. And that shaped how I thought of my life, not in as decisive ways as she did, but then I became very interested in becoming an expert on Latin America and in focusing that expertise on trying to help people and trying to make life better for especially the vulnerable and the poor. That experience led me to go to Princeton and to work with Latin Americanists in the history department and in the political science department. Princeton had a thesis that you had to do for the final year. And I got a fellowship to go to Mexico to study Carlos Madrazo, who was a politician in Mexico. I met him and I did a lot of research in something called the Emeriteca, the newspaper library, to write up an analysis of his attempts to make the Mexican system more democratic.
Mm-hmm.
So I became then also more interested in doing research, right? And in trying to be a good analyst and to analyze that and to make it make sense. And I wrote, I think, a pretty good thesis. And that led me then to go to graduate school at University of Wisconsin, which at the time had one of the best political science departments in the country and was also a center for Latin American studies. They had a land tenure center, and I worked with two political scientists who were experts in Latin America. So I built that kind of career. I was working toward becoming an academic, working on Latin America with the starting point of Mexico.
When did you first get interested in issues of health?
Well, I chose to do my thesis, my doctoral dissertation, on Chile and on the Allende government. My interest then was in combining the arguments that different political actors would be making about what should be done, which was a kind of ethical, political analysis, policy analysis, with the difficulties of building a coalition of supporters and how they argued with each other. So my thesis was on Latin America, on really South America, on Chile. And I was in Chile for 9 months in 1973. I left Chile 3 days before the coup because my mother was dying of cancer and they called me back. I was expecting to go back to Chile. And then there was the coup, and the military raided the apartment building I was in and burned my books, some of my books, in the street. And I could not go back, but I wanted to. So I wrote a proposal to do a study of the post-coup period in Chile. And I thought that the first thing that the military would do would be to dismantle the national health system, which was built on socialist principles. And so I thought they would be the first. I was wrong about that because it took them quite a while to decide what to do about the national health system. But of course, nobody in their right mind would send me back after the military had raided my apartment. But there was a Center for International Health at the University of Wisconsin, and the director of that read my proposal. And he said, "Would you be interested in being the deputy director of this program?" And I was trying to find work to do to finish my dissertation because it had slowed down because of the coup. And that gave me the opportunity to do that. And that program had a location in the east coast of Nicaragua, where medical students from all over the Midwest would do a residency or an internship in a rural area in Nicaragua, right? So I became a director of that kind of program. And that brought me to both Nicaragua and Guatemala. And having started as an expert or researcher on Mexico and Chile, I then started to really be interested in what was happening in Central America. And I built on that because people would come up to me and they'd say, "We have this wonderful program of primary care for really poor people in Latin America, but we can't figure out how we can convince the government to make it a national program." This brought me to the interest of being practical in my political analysis for those who wanted to make changes, right? Reforms, health kinds of reforms. And I did some background research, and there was no easy answer to that question. So I wrote a proposal to do that kind of research in 4 countries in Central America, right? To kind of compare countries that had been relatively successful in doing reforms to countries that were not. So most of Nicaragua was not one that was doing very good, right? Mm-hmm. But actually Guatemala was doing a fairly good program. That proposal got me a postdoc that I could do at the Harvard School of Public Health. That's how I came to Harvard, right? And I did, for 2 years, I did a postdoc at Harvard, learning a lot more about public health and spending most of my time interviewing people all in 4 countries in Central America: Guatemala, Nicaragua, Honduras, and Costa Rica. And I then wrote and published some of the results of that study. And that gave me now the expertise in Central America, right? And was the reason that I met my niece, right? Because I was spending time there. Now, when I finished my dissertation, when I had started graduate school, almost every graduate got a good job.
Mm-hmm.
In the period while I was doing my research and stuff, almost no new jobs appeared. When I graduated, I was lucky because I was what they came to call a gypsy scholar.
Uh-huh.
I would take a job from a Latin Americanist who would go on leave and be teaching a Latin American and political science course in some very good universities. I taught, just before I left Wisconsin, I taught Latin American politics at the University of Wisconsin-Madison. Then I went to McGill in Montreal, taught there. And then I got that postdoc at Harvard for 2 years. And after that, I taught at Swarthmore and at Dartmouth, 1-year appointments for each of those. And then I got a permanent tenure track position at Sarah Lawrence College, very close to where I grew up. And enjoyed that for about a year or two. But I soon became disillusioned with that teaching environment and what I was doing. In fact, when I came up for renewal, they told me to take publications off of my CV because they thought I wasn't teaching or as devoted to teaching as they wanted. And I became more disillusioned with that teaching opportunity. At the same time, I was teaching brief courses 1 or 2 days at Harvard. I would do some things on political analysis for courses in health planning and that sort of thing. And while I was about to teach one of those courses, a call came from someone I had interviewed in Central America, in Guatemala. He said, "I'm about to retire. I would like you to come and evaluate my project."
Interesting.
It was Project Hope in Guatemala. And to do that, I would have to work with a consulting firm in Washington.
Mm-hmm.
And so I did that. And that gave me an opportunity to use my expertise in both Latin America and in primary healthcare issues and in politics, and to join people who are now called consultants. And I did a lot more consulting through that venue. The company that hired me then started to hire me for doing other things.
Mm-hmm. I'm kind of curious. You came into health planning and Latin America through concern about the poor, and you chose this kind of very strategic policy planning field instead of, say, going the route of your colleague Paul Farmer, who worked with hospitals and with actual nurses and doctors. What to you is inspirational or so valuable about this kind of consulting work?
That's a very good question. Well, first of all, one of the things that Paul Farmer has is he's a doctor, or he was a doctor. And so he had that practical skill in clinical medicine that he could then use for the kind of work that he was doing, directly helping the poor. I'm a political scientist. Maybe if I had been interested in strategies for getting elected or doing that kind of political science, I might have had some more practical experience. But as my academic career evolved, I became more interested in how do you do research to find out whether what you're doing is actually effective. And so I learned a lot more about methods and how to do that kind of research, and also how to phrase it and present it through both that kind of academic work, but also especially through consultancy, how to work with ministers of health and persuade them to do the things that I thought my research showed. And that skill develops over time. You don't it's not something you learn in a classroom very easily. And in some sense, and I've always kind of thought this, I don't have the satisfaction that Paul Farmer could have of saying, I saved somebody's life. I can't say that the kind of ideas that I come up with, the research that I do, even if I think it's solid and I can have a definite kind of recommendation, if I'm a good consultant, and this is something I learned about consultancy, I had to convince someone that it was their idea. So it's hard for me to say I have the same satisfaction out of having contributed to trying to change policy so that it will help people, that a doctor or someone like Paul Farmer could have, saying, look, I built this hospital. It saved this many people's lives. The person that I touched was saved. I don't have that. And I think a lot of my colleagues who do the kind of work I do also have that kind of tentative feeling, well, we thought we were trying to do good things, but if we apply our methods, we're trying to figure out whether we actually had an impact. We don't. I often think the experiment in international living had a tremendous effect on me. It caused me to choose a career in Latin America. If I were to go back to that program and say, were you effective? They would never have found me, right? And so it's really hard to know, for the kind of more abstract, less direct contact, what you do. The other thing, I think this is interesting because I've worked with some people, the brilliant health economist, Bill Shao, who hired me to come back to Harvard 25 years ago. He was an expert in how to pay physicians through Medicare and Medicaid. And he designed a very interesting program that was able to increase the salaries of family medicine and of the more effective types of prevention and promotion kinds of work that we need in our health system. And right now we're suffering from some of the problem because we don't have enough primary physicians around. He was able to change that policy, and he could see that he did it for a period of about 5 years. He was a good health economist, and he designed a very interesting program, but he was not a good political scientist because the surgeons and the oncologists were able to capture the institution that made the subsequent choices about how to pay physicians. And they recaptured the payment for those kinds of physicians. And so he was very effective for a certain period of time. Mm-hmm. But again, you have to kind of think your contribution is not going to be as direct or as maybe long-term as some of the things that someone like Paul Farmer could do. But, I don't know. I haven't been back to Haiti where Paul Farmer did some really impressive work. I don't know if even his hospital is able to survive the kind of political and economic changes that are happening there now. I do feel that if I think of the other careers that I could have chosen as a Princeton graduate, that would have been in finance in New York City. And I don't know that anyone who works in that feels that they have helped poor people around the world have a better life. I do think that the research that I've done and the work that I've done as a consultant and even the training that I do of others is likely to have a long-term effect on the benefits for people in poorer countries.
So when you first started as a consultant, you were working only in Latin America, is that correct?
Yes. The first one was in Guatemala, right? So it did start that way. Mm-hmm. But because I also speak French, the consulting firm then hired me to work in, I think it was Rwanda. Uh-huh. So I started working in Africa. Now, in Africa, English speakers are dominant in the consulting world because they mainly work in the English-speaking parts of Africa. But at the time, there wasn't as much competition for working in Francophone Africa. So I was able then to begin to build an expertise on Africa and
Hmm.
on how Africa might be different than Latin America.
Hmm. You've worked in 80 countries, if I get that right, around the world.
That's right, almost 80 countries. I mean, after Africa, and I've worked a lot in Africa, I had a major program in South Africa right before I retired. I worked in Indonesia, right, which is not only a huge country. At the time, it was 180 million people. It's now even more. And it's Islamic. It's the largest Islamic country in the world. So I learned a lot about that kind of culture and a lot about that part of the world. And it gave me a different kind of perspective than in Latin America. I don't know if you remember, I mean, sure you do. But in Latin America, I had the somewhat advantage of being seen as a leftist and not supporting American policy. But any of my recommendations they would be skeptical because they'd say, you are an agent of the American government, the imperialist government, and we don't want to accept it. The Indonesians were exactly the opposite and more like the Chinese. They said, we want to know what you were doing and what your advice is because we're going to do it better. And
Interesting.
because they didn't have kind of neo-colonial period where American was dominating everything, they weren't as defensive about learning what's coming out of the United States or even the international health community. They were interested in trying to absorb it and learn it and get as much as they could.
And how did, though, you continue to work in Latin America, particularly in Chile? How did those different experiences inform the way that you saw Latin America?
Well, of course, a lot of the things about health systems can be pretty similar from one country to the other, right? There are a lot of things that you have to think about, both the preventive medicine kinds of issues and communities and how they work. And I think in the beginning, it was easier for us to say, you should be investing more in primary health care than in hospitals, because more people were dying of things that could be solved by primary health care and preventive medicine and that sort of thing. But over time, that changes, and it changes differently in different countries. And so what happens is you begin to lose the justification for that kind of simple solution. Put more money into primary health care than into hospital. But when more people begin to die of chronic diseases, you may want to do more to try to prevent them from getting those chronic diseases, but they're still going to need a hospital, right? And so you begin to change, and that change starts, I think, more in Latin America before it starts in Africa or in Indonesia and in other countries. But the other thing was that I got also to work in Central and Eastern Europe. And so I saw then the difference between the Soviet system that was evolving in these countries as the market started to change,
Hmm.
and to see what it was that they were learning. And in fact, I wrote an article that the Poles didn't like very much, comparing Poland to Colombia,
Uh-huh.
because they're both Catholic countries. They're both about the same size. They both had about the same income levels. And the Poles didn't want to know what was going on in Colombia because they wanted to know what was going on in France. Their benchmark for what they wanted to do was a much more developed country than they were. And so they were trying. So I was trying to use the arguments about what you do in less developed countries in places where they wanted to know what are you doing in the most developed countries.
That's absolutely fascinating, Tom.
And after I came back to Harvard, I became the director of a project in Colombia that was a health reform that was built on the same principles as the Clinton plan in the United States, the managed competition model. And the Minister of Health was very proud of the fact that he was able to achieve his reform and the Clintons were not able to do. And so I learned and became much more of an expert on that, as people now call, as you know, the neo-liberal approach to health reform and to other kinds of reforms. And as someone who has much more of a background in and favorable opinion of socialist responses, this was a problem, but I learned a lot out of that system and out of what we tried to do there. And therefore, when I look then at the Soviet system being evolved and changed in Central Europe, often in Colombia and in Poland and in other countries, I would say don't look to the United States for lessons of what you should do. Look at it for what you shouldn't be doing. Because I kept saying to the Poles, especially, they said, well, the market's going to solve all our problems. Because they were so used to such a rigid Soviet system. So most of my recommendations had to be careful. Don't create a system that's going to be difficult for you to change and to actually achieve the objectives that you expect. And so that kind of experience and an evolution of how we think about things was really important part of that part of my career.
And what lessons can you give from all this time as a researcher, teacher, and advisor in almost 80 countries? And I looked on the website and it said health reform, decentralization, sustainability and implementation science, social capital, policy analysis, organizational and institutional analysis, human resources policy, public-private relations, community development, and project design evaluation. That's incredible. Can you distill and give us, say, 3 or 4 important lessons you've gotten from all that?
Well, you might say that I followed a lot of stats, and some of that is something that is necessary, I think, for academics and for consultants. You need to know some of the things that people are thinking if you want to have an influence on the policies that they may choose. Mm-hmm. So that may be an important thing. You may be skeptical about some of that, and I was about the neoliberal approach and that sort of thing. So I think that's one of the lessons. You mentioned many of the different things I've been involved in, but the thing that I'm known the most about, and something we will in the David Rockefeller Center have a seminar on, is decentralization of healthcare systems. I came to that because Bill Shao told me, he said, if you want to stay at Harvard, you need to become a world expert in something. I looked around and I was working with a lot of health economists. And I said, I'm not going to become an expert on financing or payment or some of the other things that they were experts in. But I had written an article that was published about decentralization in Indonesia. And so I said, I'm going to become an expert in this. And when I looked at the literature on that, I was appalled because most of it was advocates rather than researchers. Mm-hmm. People that thought decentralization was good, and they just were picking and choosing things to show that it was good. And those who thought it was bad, doing the same thing. So that launched me in an area of saying, look, I'm going to try to think about how do we analyze this, and then how do we do research on it. And I was fortunate to get USAID support at that time. They were funding more things on doing good research to find out what kind of policies they should be pursuing. And that gave me the opportunity to develop a way of approaching and thinking about decentralization that I call decision space, and then to study it in a variety of countries. The first countries I studied it in were in Latin America, Chile, Colombia, and Bolivia. So I was able then to evolve into doing it that way. The other lesson, I think, that comes out of that kind of career, and one that I think also happened to my wife, is when you're in graduate school, you think you only have one career. And I was lucky in that I was able to start that career, build it on the expertise of being a PhD, and no one expects me to get more than that. And therefore, I had a kind of discipline and understanding that people could respect both in academia and in consulting. But that I also was open to opportunities. And as they came along, tried to build on my skills and work toward doing something different. I dropped academia. I became a consultant. I ran a huge project for USAID all over Latin America. And I proved myself as a good manager, even without much management training or experience. But I took advantage of that kind of opportunity. And I try to tell my students when they ask me about that, I said, well, yes, you need to establish a good, strong, disciplined background that might be good enough for the career you want, but also for other kinds of careers. And that you'll be much happier. When I got to Sarah Lawrence, I thought I was going to do very well as an academic and a teacher and a trainer and that sort of thing. I wasn't happy when I was there. I found that it wasn't the kind of institution that I had expected. And so I would have been a very unhappy person at this age had I stayed in Sarah Lawrence as a tenured faculty member. I took advantage of just giving that up. I was given the great opportunity to come back to academia in a more practical way, in a school of public health that is both interested in academia and in the practical side of how you apply the ideas that you developed and the research that you've done. And so I was able to combine both of those careers, the consulting and the academic career, in a way that has been very, very satisfying for more than 25 years. It did give me that opportunity not only to find out about other parts of the world, but I was able to continue to work in Latin America. And because I was able to do the course in Chile every year, I was able to keep up with what's going on there. Now, one of the problems and one of the things that I think is a caution about my kind of career, moving from being an area specialist to being a global specialist, is that I do no longer able to keep up with the literature and even with who's the president in different countries in Latin America. And that is a loss. I'm not an expert on the things that I used to be an expert in. But I think having been able to learn about other countries and to pull some of the ideas that come from other situations into and applying them to Latin America has been a compensating advantage.
I sense that Latin America has a special place in your heart.
Oh, certainly. Yes.
Thank you for taking the time to talk to us on Faculty Voices. We've been listening to Thomas Bossert. He's a senior lecturer emeritus in the Department of Global Health and Population of the Harvard T.H. Chan School of Public Health. Until 2022, he was the director of the International Health Systems Program, IHSP, that sponsored many research projects and executive training courses. And we consider him to be one of us at the David Rockefeller Center for Latin American Studies, Dr. Class, through the program he conducts in Chile. Thank you very much for being with us on Faculty Voices.
Well, thank you, June, and so nice to see you again.